regarding placement of ports for laparoscopic surgery of the pelvis. Again, the same principles will play in mind. One is a manipulation angle, that is the angle between the two instruments to work with. Number two, the elevation angle, the angle at which the instrument goes into the body so that it is easily done by you. And the third part is the instrument, half of instrument should be inside and half of instrument should be outside. When compared to renal surgery, the pelvic surgery is a little different because of, in lieu of, suppose if you take a prostate which is likely to be in this area, the depth of the length between the port and the target area may be little high because it is deep inside. So to reach the prostate, you need to plan the ports in such a fashion that at least that the major part, both the parts which are existing inside and outside are almost the same. Give me an instrument. Laparoscopic. So you need to place the ports in such a fashion that half of the instrument, or at least half of the instrument, is inside and the rest of the half of the instrument is outside. If you take a needle holder, if you see this is going to be the half of the instrument and that is going to be the first half and this is going to be the second half. The first half has to be inside and the second half has to be outside. So accordingly, you should be able to plan the instrument. So it is not that in general it is said that one is at the umbilicus, one is pararectal, another is pararectal, another is above the iliac spine. It cannot be said like that. Give me the scale. You should always be understanding what is the distribution of this abdomen. What is the length of the abdomen above the umbilicus and what is the length of the abdomen below the umbilicus. And don't plan the instruments, as I said before adapting to the pneumoperitoneum. Next, please. So before we start any port positioning, you have to complete the pneumoperitoneum first. See how much is going to be the distension, because assess the length below the umbilicus, assess the length above the umbilicus, and then plan the ports. It's not general saying that everything should be in line of umbilicus or it should be in a semicircular fashion all around the umbilicus. No, it can be in a semicircular fashion or it may be in a W fashion depending upon the distension or the length which is available or the amount of abdomen which is seen just below the umbilicus. Suppose if the length is small, in which case you may have ports coming up right at the level of umbilicus alone. Suppose if this length is too high, your vision port may be still at the umbilicus and your ports which are going to be manipulation are going to be below the umbilicus in a W fashion like this. So you need to understand that only after creating the pneumoperitoneum. Now the pneumoperitoneum is being created, you should have the first port, how it has to be planned. So how do I plan routinely in any laparoscopic surgery? What are all the types of laparoscopic surgery? Let us look into prostate or something in the center of the abdomen or onto the side, onto the lower ureter on this side or on this side. When the lower ureter is being planned on this side, your port positionings are going to be triangulated in that direction. That means your telescopic port may be here or maybe a little away this side, and your other ports which are going to be working ports are going to be on this direction. So you may be working in this way from standing from the other side of the table. The same way, if it's going to be lower ureter on this side, you're going to have a hand instruments being placed in this direction and the telescopic port is being placed in the direction. So it can be in the midline here, pararectal here, and the telescopic port is going to be here. The same way, on this side it's going to be midline here, pararectal here, and the telescopic port, and you're going to stand on the other side of the table. When it comes to midline, or when it like the prostatectomy, which is one procedure which everybody wishes to understand well, you can see it from the midline, above the umbilicus or a little above, because telescopy is one thing which you want to get away from your manipulating instruments, and you want to keep the telescopic away, so you can keep it above the umbilicus or much higher than the umbilicus, and you can reach with the telescope as low as possible. Now comes to your instruments. How do you plan it? The instruments are going to be on both the sides. Majority of the times, if you are standing in the head end of the table and you are able to work in this direction like this, it may be variable. It may not be possible every time. If the length of the patient is too much, if the height of the person is too much, your pelvis must be much more away. So it may not be possible to stand at the head end of the table and operate all the time. So in majority of the times you may be sitting or standing on one side of the table, especially out on the left side of the table, and then planning the positioning of the positioning for ports. Can you get the head end down still? So in these cases, what I do more routinely is, anyway, your telescopic port is going to be in the center, and now because I'm going to be standing on this side, on the left side, and I'm going to be the right hander, if you really place 8 centimeters or 7 centimeters on this side and 8 centimeters on this side, my hand on the right side, which is my dominant hand, is going to be much away, and I'm not going to work with this dominant hand very well. This may be good if I'm going to stand at the head of the table in a small patient, but the same thing may not be true in a patient who is large, and I'm going to stand on one side and putting my hand on the other side to work with. So in this sort of a direction, what I do mostly is I keep my instrument, which is going to be my right hand instrument, at near to the port on the telescopic port, and my left hand instrument a little away from it. This is going to be one, and this is going to be one. So one is towards the midline, another is away with it. By this fashion, I'm not straining my right hand to get across onto the table and work with. I'm still standing here and still be working here. I don't mind having a little nearer to this telescope, but I'll be able to work in this direction. So my left hand port is going to be little away, and my right hand port is going to be little nearer to it, so that the manipulation angle which can be there between the two is maintained at that probably 60 or less than 60 degree direction. The azimuth angle on this side is going to be less, the azimuth angle on this side is going to be more. That means azimuth angle is nothing but the angle between this instrument to the telescope and that angle between this instrument to the telescope. You may put that. So this angle is maybe smaller, but that angle is going to be. Now coming to, so this is going to be the prostate, and this is going to be my port, and this is going to be my port on the left side. So this angle may be 60 degrees, but this angle may be 40, and this angle may be only 20 degrees. So this is how we plan when you do a radical prostatectomy on a laparoscopic patient. But so when you say this is going to be the angle. The port can be placed here, 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 or even sometimes the port can be placed here. In which direction you want to keep the ports depends upon the distance between the pubis and the umbilicus. If the distance is longer, your ports are going to come nearer, below the umbilicus. The distance is very short, they are going to come at the level of umbilicus or sometimes even above the umbilicus. So distance of this will decide at what level your ports are going to be placed here. In this patient, if you think about, I may be placing the ports here on this direction because the distance between this expected prostate and this to the port here, what is it? Is nothing but 15 centimeters. So I expect 15 centimeter of the instrument inside and a 15 centimeter of the instrument outside. The same thing is here. 15 centimeters here and a 15 centimeters here, so that my working will be easier on both the directions. So half length inside and half outside. And my angle of instrument is in this fashion, which gives me a probably 60 degree angle to the flatness. I can change this angle by tilting the table on this side or that side, but I can have this sort of an angle which goes inside so that I can place the ports here. Suppose if I place the port here, what will happen? My angle of instrument is going to be like this. If I place a port somewhere here, my angle of instrument will be like this because that has to go towards this target. The ideal angle of incline is going to be 60 degree like this. So that will make me do it's on the level of my elbow, and that is going to make me do the things better. So that is how the ports are going to be being planned. There are French surgeons which puts both the ports in this direction and keep the telescope here and start working on this so that they don't have a strain to work in this direction. That's called sectoring. Keep your hands on both this here and keep the telescope here. See it from one side and keep these two instruments on this side, and that is called sectoring. So a minimum degree less than 60 degree has to be maintained to have a proper action. That is called manipulation angle. Should not be more than 60. It becomes difficult. It can be even 50 sometimes or 45 sometimes. But this angle has to be maintained. And my personal opinion, I'll keep this right hand port a little towards the midline and the left hand port a little away so that I can work in this direction without much strain.